This week on Physio Foundations, I'm talking to Matt King, Dr. Matt King from Trobe University about his research and clinical interests. We're going to talk about femoroacetabular impingement syndrome, biomechanics, and many other exciting things. Stay tuned. Welcome to the Physio Foundations podcast for another week. This is a podcast about the knowledge and skills that provide the foundation of expert clinical practice. And this week, Zuzana and I are co-hosting. So hi, Zuzana.
Hello, Luke.
And we've got Matt King on the line. So Dr. Matthew King from Trobe University and the LASM, or is it the LASM or the LASM group at Trobe. Matt, how are you going?
Well, thanks, Luke. Thanks for having me. Good to see you, Zuzana.
Good to see you.
So Matt's got a lot to offer. He's got a lot of clinical and research interests. And I thought rather than me doing my normal big bio introduction, telling everyone all about you, why don't we start with a bit of general information about who you are, Matt? So can you give the listeners a bit of a brief introduction about your background and current interests and why we're talking to you?
Yeah, absolutely. So as Luke said, my name is Matt. I'm a physiotherapist and have been for the last 10 years. And I am currently employed at the Trobe Sport and Exercise Medicine Research Centre, or LASM, as it's commonly referred to, as well as a lecturer at the discipline of physio at the Trobe as well. And I currently split my time up between those two roles, looking at research relating to biomechanics, hip and knee OA, and also do some large-scale data management for the centre as well. In the past, I've worked clinically across community sport as well as Premier Grade rugby, and I've also worked as a consultant to the Transport Accident Commission on their clinical panel as well. So that's kind of me in a nutshell.
So, Zuzana, whenever you want to jump in with a question and a curly question, you're going to ask Matt some curly questions today, please jump in. I wanted to ask about, if we go back to your PhD, Matt, and your PhD investigated biomechanics in athletes with hip-related pain. So what got you started in research and in your PhD? And perhaps you can give us a bit of a summary of your research and your findings.
Yeah, so what got me interested in research actually was as an undergrad student, being a participant in someone else's research, Dr. Adam Semke, who is also at the Trobe, who actually subsequently became one of my supervisors. And from a biomechanics perspective, I'm very much not a words person. If anyone that works with me will attest to that. I'm very much about numbers. Come from enjoyed physics and maths at high school. So that's what really drew me to biomechanics specifically. And I remember I caught up with Tanya Pizzari, who's a physio lecturer and works at Mill Park. One day right before LASM was about to start, we were having coffee, and we've had multiple conversations in the past about me starting to do a PhD. And her exact comments to me were, the Trobe's going to start a new research centre. You either jump on the bus now or you don't do your PhD. I've arranged for you to meet Kay, the new director, tomorrow. Don't be late. And that, I suppose, is how my relationship with Kay Crosley and my research career started. So I'm very glad I went to that meeting the next day. I was very scared because I kind of knew who Kay was, and I did some Googling when I got home, and then I was even more scared after that. But she's not a scary person in real life.
It's a good story. So you started your PhD, and then tell us a bit more about what you did. So biomechanics focus and... Yeah,
biomechanics focus. So I worked on an NHMRC funded project that Kay got a grant for, and her team, looking at the biomechanical risk factors and other risk factors associated with the progression from femoroacetabular impingement syndrome towards hip OA. And I worked on the biomechanics component of this, predominantly at baseline. So I was looking at the biomechanical factors associated with an individual's presentation with hip pain, and how that can inform assessment, guidelines and treatment strategies further down the track.
So what were your hypotheses at before you started? Like what were you thinking you'd find?
That's a good question. think my hypothesis prior to leading into the project was predominantly around, I suppose, issues are always going to present themselves in larger amounts of hip flexion and larger amounts of tasks. So you're jumping, you're hopping, you change your direction, those sorts of things. Whereas being a younger cohort, we wouldn't really see too many issues from, let's say, a walking perspective or those simple things. That was what I thought going into it. That's certainly not what I thought coming out of it, but they were my initial thoughts rolling forward.
Fantastic. And I guess did it change though? How did it change then? So what were your thoughts afterwards?
Well, because of that, we deliberately picked to look at a low level task and a high impact task. So walking, because it's relatively commonly investigated, but also single leg drop landings as well, high impact, high magnitude, single leg. But we're actually, as we started to peel into things, we were looking at a younger cohort that was still playing football, so soccer or AFL. What we found was that the differences that were present were actually more prevalent in those lower impact tasks like walking. There actually weren't too many differences in the higher impact tasks, the single leg drop jump type movements. And we put some hypotheses as to why this may be the case. Maybe these particular individuals that we were studying, because they were still playing sport, they were still participating 2 to 3 times a week. Maybe they weren't deconditioned. Maybe they weren't underloaded from having time loss injuries. So they're still able to perform those higher impact tasks with relative ease.
And that's particularly useful for clinicians that are working in teams, because obviously when you're working with teams, you want your players to continue training as much as possible, and even if they're modified. So that's really, really useful for those, because the nice thing about that project is there wasn't necessarily an intervention in it. You've got a cohort that are going about their everyday thing, which is, in clinic, that's what you've come across. People come in and they're still playing their sport, hopefully.
Yeah.
And so, this is really interesting. So I guess as a clinician, because I still work as a clinician as well as doing my PhD, I know I'm jumping the gun a little bit, but what are the sorts of things that we should be looking at with these sorts of people when they come in into the clinic? Because we obviously always want to dive into the jumping, the hopping, the running, and all of that sort of stuff. But what is it about the walking that we should be looking at? Because I don't think many of us maybe look to that straight away with the sports person.
So the more common presentation, and the interesting thing, I'm going to, I suppose, give a bit of a prelude here. The interesting thing is the cohort that we investigated was still playing sport, and we really tried to hone in on that, because there's a big gap in the biomech literature in hip pain around that. Usually they're pre-surgical cohorts. So to summarise quickly, the sport group, they presented during walking to have similar impairments of those individuals that were having surgery or had hip OA. The only difference was they were of a smaller magnitude. The impairments that they were presenting with were smaller. And one of the more common ones that pops up with hip pain is people start to reduce how much extension they go into when they walk. Because it's predominantly uncomfortable, it changes the forces in and around the hip. And it's hypothesised that the individual people that have hip pain do this to decrease the pressure or decrease the contact force in the front part of their hip. Now, we're not too sure if that's a good thing or a bad thing, and we're continually working on that exact question in the cohort at the minute. But I think for the clinicians, especially the young clinicians listening to this, I'm like, my advice would be, don't negate the simple low-level tasks. If you're taking 10,000 steps a day, whereas you may only hop and jump 400 times at training, I don't know how many times I was a ruckman, so I was doing a lot of jumping when I was playing footy. Don't negate those small tasks. And when you're setting your rehab programs up, say you're looking to increase return to running in those higher impact tasks, keep this in the back of your mind. So one of my most favourite things to do for my hip pain patients, especially when they come in initially and maybe they have stopped playing sport and they're a little bit deconditioned. When I look to return them to run, I love bleacher running or stair running, because you're getting, and what I get them to do is I get them to run up the stairs, and they've got to turn around and ideally get in a lift and come back down to the bottom, or slowly walk back down and go back up. Because you're getting small bouts of a higher impact task, but you're not challenging the hip too much by getting it to come out into too much extension and make it uncomfortable. And the other thing with that as well is there's this interplay between your ankle and your hip. And if you increase the amount of work and power at your ankle during a task, you actually start to decrease it at your hip as well. Now, again, we don't know if that's good or bad, but from a progression from return to run, like bleacher running is really, 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 I find it to be very, very useful in returning these people to sport. But there are some important caveats. Number one, they can't miss a step. It's very deliberately little short steps. Number two, then I'll let them run back down the stairs.
This is a great example of where you can apply biomechanics to rehab, and you're talking about that understanding of how the hip and the ankle have an interplay in the closed kinetic chain and movement, and just that knowledge of potentially biomechanically how the hip is loaded. And it was also interesting that you said that you're not actually sure whether it's a good or a bad thing. You can have a problem potentially with deloading or unloading a joint long term with the cartilage health, but potentially that's an adaptation in the short term if there's pain or dysfunction in the joints. I found that really interesting. And also just the thought of 10,000 steps a day versus 400 or so repetitions with a high impact activity. It's worth thinking about, not neglecting, as Zuzana was saying, not neglecting the lower impact tasks as well. Yeah.
Yeah, you can 100% decrease an individual's aggravating factors in the short term to make life easier for them, but then make sure you're building them back up into those sorts of positions as time goes on. Because you are right, yeah, and we are looking at present is what our current work is on, looking at long-term loading and underloading and overloading and what sort of effects that has on cartilage health.
As well as muscle quality.
As well as muscle quality, which is where Zuzana's PhD comes into it.
Yes. But the other thing that I find really, really interesting is you're talking about that hip extension and how that changes. Clinically, that is something that I often do with people with hip pain, is give them an exercise of just walking backwards. And particularly if they start getting hip pain during walking, just getting them to do a couple of walks backwards often sort of resets the hip, as I like to say it, and it does make a difference to them walking forwards and how they walk forwards. I also think that the walking backwards is nice because we don't often do it, and it's actually quite hard, and particularly if you do have a bit of hip, knee or ankle pain, any sort of lower limb pain as well as back pain. The other thing that it's really good for is challenging someone's balance. So you're getting that, plus you're getting them up onto their toes and almost doing like an eccentric calf. So you're getting, so you're loading the ankle joint, you're loading the knee, you're loading the hip. And we know that if you load appropriately, that's what helps with your joint health. So that's really interesting.
Yeah, I love walking back, especially for hip OA patients, and even later in the rehab phase for people that have really irritable lateral hip pain, greater trochanteric pain syndrome. I love walking backwards as a rehab progression. It's sensational.
A different central pattern, different loading of the tissues, the joints, and perhaps also have a different approach from the person in terms of if they've got any fear of movement or apprehension for loading as well. And it's one of the oldest tricks in the book it's not a new idea.
No, I agree. It's definitely not a new idea.
Well, one of your lab studies that you've got published, Matt, talked about the biomechanics of men and women doing single leg drop jumps and walking. So as examples, as you were saying before, of high and low impact tasks. And then you found some sex differences, so some differences between men and women. Can you tell us a bit about this study and what you found and what it might mean if we think particularly the sex differences as well, and maybe we can segue from there into some of the work you and the group are doing with women's sport?
Yep, yeah, no problem. So this study really came off the back of the systematic review we did at the start. And the main things that came out of the systematic review were most of the populations that are studied are pre-surgical, so they may be a little bit later in that disease continuum. And the second thing is women are severely underrepresented in hip pain research in general, especially young hip pain research, but also specifically towards my PhD, the biomech space, which is really interesting because the individuals that present the epidata shows that the split between men and women who present for FAIS surgery is half men, half women, but they're underrepresented in the research pool. So my question that I always had in the back of my head is, what effect does sex have on this sort of relationship between biomechanics and hip pain? Not everyone moves the same, not everyone is the same. So we started that off by literally having a look at men and women. Importantly, the study found that when comparing men and women at the hip and the knee, the differences that were observed were task specific. So the differences that we observed during walking at the hip and the knee between the two groups were not the same as the differences we observed at the hip and knee during the single leg drop jump task. Interestingly, at the ankle, it was joint specific. So the differences between the men and women were the same, regardless of whether or not they were walking or whether or not they were doing the single leg drop jump. And this difference was the men used their ankle and calf more. They had a greater, they created they created a greater moment and a greater impulse. So they were I'm trying to think of how to say this simply. They were making their calf do potentially more work and potentially maybe producing more power. In this particular study, we didn't look at power, but we did further down the track. This is an important finding, as I was talking about earlier, as there's an inherent trade-off between the forces between the ankle and the hip. Because if you increase the forces at the ankle, there can be a relative decrease at the hip. So, what does this all mean? And there's kind of two things that come out of it, one from a research perspective and then one from a clinical perspective as well. The important thing with this paper is it's not necessarily the differences that were observed that were the super important thing. It's the fact that the differences actually existed. And this has implications for interventions and research, especially with regards to movement retraining, because at present, most of the studies that look at movement retraining intervention target impairments that are predominantly seen in male-only or male-dominated cohorts inside the research. So we don't actually know if these sorts of techniques are applicable to women because they may be presenting with different impairments and different movement patterns. So in order to adequately develop adequate assessment and treatment recommendations, research into women, we found that research into women needs to increase, and putting men and women together in the same cohort without exploring sex in that cohort should be strongly discouraged. And importantly, from a clinical perspective, women with hip-related pain move differently. So therefore, if you're looking at movement retraining as a potential intervention or something that you're going to add to your care or something you add to your treatment, care needs to be taken and a thorough assessment conducted to establish which impairments you wish to target. And this is especially important for women as they may not necessarily present with common movement impairments that we see in the literature.
This is really
bit of information overload there.
No,
Sorry. It's my favourite paper from my PhD, and I really enjoy talking about it.
Is trailblazing what you've done in the sense that you've, as you said, women are underrepresented in that area of research, and it's so important. And Zuzana's sitting here listening to this, knowing full well the impact that musculoskeletal injuries can have on women playing high impact sports, because she's one of the physios for the WAFL teams in Australia. So that's, for overseas listeners, that's the Australian rules football and the women's division of that. And I thought you did a great job summarising simply what that means. That made a lot of sense. Zuzana, what are your thoughts on that as a clinician, thinking about girls, particularly with hip or groin pain?
Well, look, I have spent more than 10 years working in men's football. So men's AFL, Australian rules football. Doing my PhD, I don't necessarily, I'm time poor, and I've been lucky enough to be able to work with some representative teams for the AFLW. And it's interesting because I'm so used to watching how men move, and now watching women, it is different. And it's particularly different with the stop-start and the change of direction. So what I find with men is when they're changing, they tend to lead more with their lower limbs almost. So you can already see their feet moving around and off they go. With women, I see that they tend to sort of use the body first and then the legs come round. And it might just be that it's a different sport also for a lot of the females coming through, because AFLW is still fairly new. We are now getting to that point where there are more women coming into football, having a background in playing football from a really young age. But it's really still new in terms of what girls have brought up been playing. So it is different. However, I mean, you do have netball, but netball is again a different sport, because when you catch the ball, you got to stop. So it's a different biomechanics altogether. And I know, Matt, you'd have lots of opinions maybe about the differences between the biomechanics of one sport compared to the other. But purely from a clinical point of view, working in the field and working with both men and women now, I do see a difference, and I think that does have implications for the rehab and even maybe performance enhancing and strength and conditioning stuff.
I agree. It's really exciting that the AFLW space and the sport participation rates increasing in with women's and girls football. I'm going to get this stat wrong, and I'm probably going to be pulled up by some of my colleagues on it, but I think football participation before COVID, the 3 years before COVID, the football participation for community women's and girls sport increased by 30-something% in the space of 2 years. Maybe edit that out because I'm probably wrong. And someone like Brooke is probably going to yell at me for getting that wrong, but the participation rates are great. And you are right, Zuzana, like watching, because isn't it AFLW for the listeners that may not be in Australia, there's a lot of, I suppose, cross-coders in the professional space at the minute. So a lot of individuals that played high-level basketball, high-level netball, high-level soccer, high-level cricket that have come across and played and now playing in the AFLW League. As time goes on, those grassroots levels will continue to come through, and we won't see as many cross-coders, I think, as well, which will also be interesting because they would have had skill development from a potentially younger age.
I've learned a new word, cross-coder, or a new term.
Cross-coder. I only learned it when I started on the current project, one of the current projects I'm working on, cross-coder. So, yeah.
So you're both raising really interesting points about not just measuring biomechanics in a laboratory and thinking what they might mean for long-term joint health or for injury risk at the time, but also thinking about what you may be able to see with your naked eye as a physiotherapist or a sports scientist or any type of health professional or trainer or even fellow athlete, just watching someone move and seeing different movement strategies. I want to go back to the question I ask everyone on this podcast is actually more about clinical application, thinking mainly about younger practitioners. and older, more experienced practitioners who are looking back and answering this question. And I always ask people, what's the most important foundational knowledge and skills for you working as a clinician? And this time I want to do it a bit differently because I've had some great answers about everything from empathy, communication, taking a thorough interview, clinical reasoning, and not forgetting your foundational knowledge. So they're some of the answers so far. But your special interest is biomechanics. And you've given us a really good explanation about how you'd apply biomechanical findings from your research to cohorts of people. What about if people aren't sure how this stuff is measured in the lab? Let's go back to your bread and butter. So what do we mean by biomechanics compared to just observation of movement? How do you measure it with 3D markers and force plates and EMG? And how is what you do in a lab different from just what you can do with a dartfish or a mobile phone or just your eyes?
Yeah. So from a lab context, we measure, but there's different ways to measure biomechanics, all the way from 2D to 3D. We have a 3D lab space. So the easiest way I explain this to people, and it does sometimes help with recruitment for studies, is I put up, especially if you're on Zoom or something, I have a photo of Gollum from Lord of the Rings, or I have a picture from Avatar. And my question to people is, have you seen Lord of the Rings, or have you seen Avatar? They go, yes. And I go, so have you seen photos of how they did that with the people covered in the dots and all the infrared cameras? You're like, oh, yeah, that's cool. I'm like, that's what's in the basement of the building of what I work, and that's what we're going to do with you. So basically, it's a big room. There's no windows in it, which is incredibly frustrating because UV light doesn't work too well with this. It's got 10 infrared cameras around it. And those infrared cameras only pick up reflective surfaces. So we basically cover people in these little reflective dots, the little 14 millimeter balls, and put them in very specific areas on their body. And inside the floor, so the floor is hollowed out, and in the floor there we have a variety of different force plates that we get them to do tasks on as well. So the camera only picks up reflective surfaces. So we have to also be careful with staff in the lab if they've got runners on or things like that, because the cameras can pick that up as well. And then we take that information. So we take the camera data, looking at the dots and all the data from the force plates. And we take that information, and it's basically then Newton's laws of physics. And we use that to calculate joint angles, which is kinematics. And our kinetic, what I refer to as kinetic variables, and kinetic is the study of forces acting on the body. So these are our moments. These are things like power, work, and I'll stop at those ones for now because they're the common ones that you'll see. It can get more complex as you go further down the rabbit hole, but they're the main ones that we look at from our lab.
To make the point that you can't measure those moments and powers with your eye. That's something that's a function of putting together that 3D movement analysis data and the force measurements from the floor, from the force plates. Yeah.
Correct. Yeah, there is some work being done in the world at the minute using artificial intelligence to see whether or not using a couple of 2D cameras, whether or not you can start to predict some forces based on certain things. But at the minute, yeah, we use the lab space itself. And
then there's musculoskeletal modelling as well. And might have to chat to Praz from the same research group.
Yep. I'm going to shout out to Praz. Praz is currently at Stanford University working with the guys that made that specific program that you're referring to there, Luke, for the next probably 6 months on some new advanced techniques. So it'll be exciting to maybe in 6 months' time when he's back, hear about his exciting time at Stanford.
So listeners, we're talking about Prasanna Shurathan, who's our colleague, and he's a gun and biomechanist and looking at musculoskeletal modelings, which is sort of the next level when you take this data that comes from these 3D cameras and the force plate data, and then use very complicated mathematics to figure out estimates of joint and muscle loading. There we go. I've got another episode planned. Braz, if you're listening, you've dobbed in. You're coming on this to explain this stuff in simple terms. What I like, Matt, is you've taken biomechanical measures and then you're relating it to people playing sport in a way that, so you're actually thinking about what it means in the clinical application. And that's something that's been the focus of the group there for yourself and Zuzana and Kay you've mentioned, and Tanya and Praz and everyone else we've been mentioning here, part of the LASM team. So what's the, before we talk about I wanted to finish off asking you about the social side of what's it like being a part of the LASM team, because you guys do have a bit of fun together and you've got a great culture. What other, and this is a question for you as well, Zuzana, what else is going on in your team? It's not just biomechanics. There's lots of research on many different things. Tell us about it.
Before you go to that, can we do the second part of that question? Because I'd be really interested in terms of clinically. So how would you suggest a clinician go about looking at some biomechanical assessment tasks, etc., and within the clinic? Like, what would be your best sort of go-tos?
So there are, they've stopped making them, which is a little bit frustrating, but you can still get them. And you can also download some free software. So I'm talking about a Wii balance board. You can actually download some free software packages to look at balance and things using a Wii balance board as well, if you want to go down that path. Things that I like to use in a clinic. So Canova is a program that you can download. When I was still at the clinic, I used UberSense. I actually think UberSense has been bought by another company and its name has changed. I can find that out and let Luke know, and he can attach it to this. But they're small programs that allow you to record movement. And yes, the reliability may not be as good as a 3D motion capture system, but it can be a good way to record a participant, say doing a drop jump or something like that, and they're falling into some form of, say, dynamic valgus angle. They're dropping into internal rotation. They're dropping their hip. Getting them to do that a few times, and you can bring it up to them and show your participant. Sorry, I'm pretending I'm playing with an iPad in my hand. Show your patient, and you can get some basic angles from that as well. So the key things that I look at the clinic: walking, drop landings, so double leg and single leg. If obviously you got to pick your patient, if they are running as well, but obviously not everyone can run the first time they come into the clinic, because that's probably why they're there. They were the three that I really looked at from a hip perspective as well. And I'll stop there.
Very good, thank you.
All good. I've actually forgotten, Luke, the other research, yes. So there's a few things going on. This particular the fourth project that I worked on for my PhD is still going. So we've just finished data collection on our 2-year follow-up, which because of COVID, unfortunately became 3-year follow-up for some people on that. And that project and cohort is actually going to continue for 5 years. And then we've just also recently gained ethical approval to continue it all the way through to 10 years. So we're going to keep tracking these individuals for a long period of time. The other ones, I suppose, that I work on is the Prep to Play Injury and Women's Football project. So that particular project is a large-scale implementation trial facilitating the use of the Prep to Play program at community women's and girls sport. So there are nearly 3,000 participants, 300 volunteers, 60 physiotherapists that implement this, and there's about 15 people that manage it at the uni. So we're in our final year of that at the minute, and then we'll look at all the data next year and get that out. And one of the other studies that's going on at the minute is run by Adam Culvenor, who is looking at individuals that have had an ACL reconstruction and may be at risk of getting early knee osteoarthritis, and implementing a strengthening program for that particular cohort, that high risk cohort, and following them again. There are three main ones. There are a lot more. Zuzana, do you want to talk about any more?
No, I think you've covered it. I think the main thing is maybe just give them a plug in terms of you might
Absolutely.
have some listeners who would like to get involved. I know from my point of view, I mean, I enjoyed the clinical side of things, but really enjoyed the jump into doing some, casual research assistant work. So what's your sort of best tips if someone's thinking, oh, actually, I wouldn't mind looking at maybe biomechanics or just getting into some research myself? What's the best way of doing that other than just being a participant and getting Tanya Pizzari to get you in with the big boss?
Get on my case, yeah. So a couple of things. So plug for the Injury in Women's Football project at the minute. We have, there are 50 physiotherapy students at the minute that are helping us with the project with some data collection, and you're reimbursed your time with that. And we are always looking for more people to help us out with that. So if you're interested in doing that, we're trying to keep, we're trying to get students to try and help us out because we have clinicians working on another section of the project and then some data people working on another section of the project. By all means, reach out if people want to be involved. And if you want to get involved in research and something interests you, the best thing to do to start with is reach out. You've got to throw your hat in the ring at some point. If you're into hips and knees, AFLW and tendon stuff, they're the main areas that Lacen work in. Reach out. We're always looking to help put people on in research assistant positions and research officer positions. And there are jobs that pop up. From time to time, there will be some that pop up in the next month or so from Lacen for research officer positions. But the first thing is you've got to take that big leap and you've just got to throw your hat in the ring.
It's a really good question from Zuzana because it's a question that we get, both of Zuzana and I get a lot. How do you actually, from clinicians, sometimes from students, how do you actually get into research for the first time? I think sometimes people are waiting for a job to be advertised or someone to come and do what happened to you, Matt, and say, yeah, you've got a meeting tomorrow, don't be late. That's rare. Often it is just knocking on a door and showing an interest in being involved. And especially if you're a student and you've trained and you've got recent skills in data collection, in systematic reviewing and volunteering your services to be one of the people on a systematic review, for example, can be your foot in the door. I know that was the case for Zuzana on multiple papers where she helped out and got involved and eventually became a research assistant, is now doing a PhD. So it's a really good point to bring up for people who are listening to this who probably have that question themselves.
Yeah. It can be daunting. Can be daunting writing that email. Can be daunting knocking on that door at the university you work in. But just put yourself out there. We all are friendly people. We're lovely. I like to think we're all friendly people and lovely.
All you need to say is who you are, your interests, and your skills, and just express interest. It's not it's really just putting yourself out there, as you said, and it's a really good bit of advice.
I think the other thing is, and I think you're absolutely right where you started, Matt, which is, for those that aren't in Melbourne, which is where LASM is, or the Trobe University presides. Luke is at Monash University, so there's plenty of universities, but starting off by volunteering as a participant can be really, really helpful. Number one, you're helping them out. It is quite a hard task getting participants and putting them through the process. But then you're able to actually see the process and you're able to meet people face to face, so researchers themselves, and you can create some really nice contacts and some really nice leads just from a session as being a participant. So for anyone that's interested in research, please do. There's always many, many studies that need volunteers. And like you said, Matt, some of the studies you can get vouchers or, you know, some prizes for just going into them. So it's definitely well worth it.
And we have 3 current research officers at FAIS, and they put their hand up to be a control in the study, and they said to the researchers, "Hey, look, I'm super interested in research. Now, how do I get involved? How do I get involved?" And now those 3 individuals are working on projects in the team. They were physio students at the time. They're like, "I really love this. I like science." Usually the conversation, at that particular time, was, "Unfortunately, we don't have any spots at the minute, but by all means, keep in touch. You know, reach out every now and then." They reached out. They're working on the projects at the minute with jobs. So it's daunting, but you just got to put yourself out there.
Yeah, great tips. What about what's it like working at LASM, and what sort of social events do you do? I think the reason I'm asking this is because it's actually really important, for particularly evident during COVID, when a lot of knowledge workers had to go and work at home, and wasn't that fun if you had kids, and it's isolating, and it's the case for a lot of people. So then you get to really see the value of a social group. I know you guys kept together regularly with Zoom and socially on Zoom, as well as your meetings. So what's it like being a part of the team there? What's some more lighthearted, funny banter
stories and points? Yeah.
Stories.
So it is a genuinely sensational place to work in, and I feel so lucky that I get to get up every day and walk into that building. It's a bit stereotypical, but it is an extended family for me, and the centre itself is very pro on family. Like, we're all in this together, and it's not just the team members all in this together; it's the partners and the kids. So we celebrate people's wins, but it's also important not to commiserate, is probably not the right word, but also reflect when things don't go to plan, because academia in itself, always getting feedback, always putting grants in, you're getting knocked back. It's important to also reflect and have people's back on there. And I've been giving this question some thought, what makes LASM? And I think there's probably 2 main themes. One of which is, if one succeeds, we all succeed. And that's really a mantra that filters through the centre. And I don't mean this just to say an altruistic based statement, but I think, the team puts other individuals' success before their own. To see people just drop their work to help someone who's got a grant due in a week, and you've got 15 people playing second fiddle to an individual to help them get through, and reading this or doing this or checking these numbers or checking a budget. That's what makes LASM. That's what makes LASM a great place to work, because it comes back around when it's your turn and you're under the pump and you're trying to meet a deadline. Bang, there's 10, 15 people knocking at your door. Like, what do you want me to do? What do you need me to do to help? I'll get you this. And it could be as simple as getting your lunch one day when you're flat stick, or it could be checking your work, checking your budgets, checking anything. And one of my favourite stories to tell is everyone helps everyone. I've had Professor Kay Crosley and Professor Jill Cook putting Vicon markers on a participant getting ready for data collection. There may be some professors out there that wouldn't do that, but everyone pitches in.
It's real leadership, isn't it? So you're celebrating those wins with each other and supporting one another, and there's also that process of reflection, which is so important. That's just come up there, and of course teamwork. So it's a really great answer to that question. And talking about being flat out, we're really grateful for your time, because you're flat out at the moment, as you probably always are, as a researcher writing another grant. So, we really value having you on here. I was going to do it in 2 parts, and this has become one big episode because we've been having a good old chat, and that's fine. So I normally do 20, 30 minutes. We're going a bit longer, and that's fine because we've covered some really important ground. I was thinking in terms of some fun, when I mentioned funny banter before. Last time I hung out with the LASM team was at the Sports Medicine Australia conference,
In
was it
Queensland,
2019 in Queensland at a conference where a young Matt King got very frustrated. The bar closed early, and then
Standard
had a
Matt
few.
King frustration.
Oh, he wasn't frustrated. He was very happy, and he just said, "Oh no, I've got to let me have a chat." And he went up there, and before we knew it, the bar was open again, and it went till late. How'd you do that? What did did you present a financial argument, a cost benefit analysis of some sort, or
there was some presentation? Oh, trust me, I never get anything from a smile. It was just the social event, because no one was at the bar because everyone was at the social event for SMA. The social event had obviously finished, and we were a couple of the first people at the bar, and they were cleaning up, and just highlighted that it may be a large group of individuals coming to enjoy a drink. And that was good. It was good. That came up a couple of weeks ago as well, that story, from someone else.
You made them some money, but the bar staff didn't look too impressed when they opened it back up again, but it was very funny.
That's good. That's good. They were fine. That's good.
And you actually won an award at that conference, which has been forgotten. Everyone just remembers when you reopened the bar. So
yeah, I did. It was good. As I was thinking on the paper we were talking about earlier, the sex-based biomech comparison paper.
Yeah, really important. A trailblazing paper that you did, and then you won an award for it. But we'll just remember when you reopened the bar.
Thanks.
Anything else?
Thanks. I unfortunately won't be at SMA this year, unfortunately. So someone else is going to probably have to facilitate that bar opening.
Someone's got to fill your shoes and carry on your legacy and your work. Well, anything else that you want to add, Zuzana and Matt, to this interesting conversation?
I just want to say thanks for having me. It's been great. If I was, to leave on a point, is just, if you ever want to, just reach out by all means.
Don't be shy. You don't have to do a big marketing exercise and be nervous in any way. Just know that if you've trained if you finish your training in the last 10 or 15 years, you have very marketable research skills. You know how to do at least systematic reviewing. You've probably been involved in some data collection. You can be a participant. You can knock on some doors and get involved in research. It doesn't have to be an advertised position. So it was a very good point that you both brought up. All right then. Well,
awesome.
Listeners, if you made it this far, you must be interested and you must have found some of this interesting. So please share. Find the little 3 dots, press the share button, and that really helps us get these podcast episodes out to people. There's stacks of podcasts. You probably don't even know about it. I find new podcasts every day, and I think, how come I have never seen this before? And it's probably because no one's ever shared it with me. So you can really do us a favor and do that. And when you do share it, tag us in @Periton Physio. You can also find Matt on the LASM website. What is the best website for you, Matt, to look you up?
For information, probably the best one is to go through Twitter. So it's Latrobe @LatrobeSEM, and then my Twitter handle is MattKing_physio.
Excellent. Now it looks like you're out of time because someone's arrived at the door. So we'll leave it there. But thanks very much to you, Zuzana, and to Matt for the podcast chat today. Thanks for coming on. Really appreciate it. And I hope to do it again.
Thank you very much.
Thank you.
So till next time, this is Matt, Luke, and Zuzana wishing you all the very best with your studying, professional development, and lifelong learning.